Thank you. So we will be talking about probiotics in necrotizing enterocolitis, a preventive approach. So we will be talking about what is the challenge, how is dysbiosis important, the role of short chain fatty acids, probiotics, how do they help, Bacillus clausii, and key insights. So, NEC uncovered, understanding the challenge. NEC is the most common serious gastrointestinal disorder in preterm infants. It is the leading cause of preterm infants' death between 2 weeks to 2 months of age. And we have the classical necrotizing enterocolitis for infants born before 28 weeks. Suddenly, it appears relatively suddenly between 3 to 6 weeks after birth. Less commonly, this can be transfusion associated, atypical, which happens within the first week, or in a term infant if he has underlying problems like birth defects, congenital heart disease, or he suffers hypoxia, he can develop necrotizing enterocolitis. So it primarily affects infants below 32 weeks, and as the gestational age increases, the incidence decreases. Global incidence is between 2 to 7%, and for birth weight below 1500 grams, it is about 6 to 10%. 70% happens below 36 weeks of gestation. It accounts for nearly 8% of all NICU admissions, and 7 out of 100 very low birth weight infants can develop NEC. In congenital heart disease, the incidence of NEC is around 3.7%. In India, the incidence of NEC is about 1.26%. So the higher occurrence is linked to immature immune systems and the less diverse gut microbiome. So what are the results? It can result in abdominal infection. You have necrosis can lead to perforation. Long-term complications include strictures, short bowel syndrome, and growth failure and developmental delays. Mortality rate in NEC is high, 20 to 30% in NICUs. The long-term problems not only affect the survivors, it affects their parents. You have the chronic intermittent GI symptoms. You have poor body image, painful scars. You have social concerns. You have behavioral issues. It can lead to psychological concerns. And it is financially taxing. So prematurity is the single most important risk factor in necrotizing enterocolitis. Maternal factors, starting with maternal microbiome, maternal hypertension, stress, smoking, this all seems to contribute. Among the neonatal factors, the most important one is prematurity, dysbiosis, premature immune system, and mode of delivery is important. The children who are born through LSCS tend to have a less diverse microbiome. An ICU environment, antibiotics, acid suppressing agents, acute hypoxia, they all contribute to GI insult. So we have the pathogenesis where there is increased toll-like 4 receptor expression, increased ER stress, leading to polymorphonuclear infiltration, bowel necrosis, gut barrier disruption. So the critical is gut barrier disruption, and the diagnosis of necrotizing enterocolitis is primarily clinical initially. So the important thing is to watch for feed intolerance, watch for abdominal distension, bloody stools. Clinically, you can have lethargy, apneas, and feed intolerance. Among the X-rays, subsequently, you can have dilated loops. Ultimately, you can have pneumatosis intestinalis, and you have the other lab tests as we go along. So tissue biomarkers, injury biomarkers have been correlated. You have the role of NIRS, Doppler, you have the stool biomarkers, clinical and serum blood markers. Importantly, short chain fatty acids like acetic acid, propionic acid, and butyric acid are being investigated as biomarkers for early detection of necrotizing enterocolitis. So here the key element beyond prematurity is dysbiosis. So in first 1000 days, the preterm infant experiences more gut dysbiosis than the term infant. And in the natural term baby, there is a natural progression from facultative anaerobes to strict anaerobes, and from a low diversity to high diversity. So in preterms, you have elevated pathogen levels, and there is lower microbiota diversity in preterm infants as compared to the term baby. So this diversity needs to be regulated. So as they age, the diversity increases and variability decreases. Now, the gut microbiota immune system relationship is there, which is vital for infant growth, and its disruption can lead to condition like NEC. So dysbiosis is caused by physiological immaturity and elevated oxygen levels that inhibits strict anaerobes, increasing the risk of chronic diseases. So it starts with bacterial invasion. Subsequently, you have inflammation and destruction, immune response alteration, increased inflammation, and immature defense mechanism. So this is more theory. We will go into the practical aspects subsequently. Premature and very low birth weight have underdeveloped immune systems, and that is why they are more susceptible to pathogens, leading to immune dysregulation and dysbiosis. So you have the whole mechanism where you have the inflammatory response and cellular damage and gut barrier injury. So now the role of short chain fatty acids. Short chain fatty acids are the end products of bacterial metabolism. They play a pivotal role in mediating immune development. Acetic acid, butyric acid, and propionic acid. These are the three main short chain fatty acids that are present in the human colon, and they are important for promoting tight junctions and increase in mucin production. So these short chain fatty acids are important to enhance the gut barrier integrity and reduce inflammation via epigenetic modifications. So infants with NEC tend to have a lower level of acetic acid, propionic acid, butyric acid, and short chain fatty acids. So these short chain fatty acids, they protect intestinal cells by inhibiting the pro-inflammatory cytokines and chemokines through signaling pathways. And you have the integrity, you have mucus layer restoration, and finally decrease in inflammation. Now, how do probiotics help in this? Probiotics, they treat dysbiosis by restoring the microbial diversity, regulating the gut microbiota, enhancing immunity, increasing the beneficial bacteria, and alleviating symptoms of various diseases. So this is the details of what the ideal probiotic strain would look like. They work through various mechanisms, which we have just spoken to, and probiotics have been studied as single strain and multi-strain. So there is microbial diversity. The most extensively studied strains include the bifidobacterium and the lactobacillus and the streptococcus. So they help in intestinal barrier protection and help in NEC. Now there's a Cochrane review on preterm infants for prevention of NEC. This is in 2020. 56 trials were included, 10,812 neonates covered. And the conclusion of the review of these 56 trials is that probiotics can significantly reduce the risk of necrotizing enterocolitis. IAP Consensus Statement 2022, they have again reviewed the entire data. Probiotic supplementation was continued till discharge and or till the child was reached full feeds, and the duration is 7 to 21 days. And the meta-analysis showed that there is a reduced risk of NEC stage 2, late onset sepsis and mortality. The strongest association, however, is with NEC stage 2. They reduce the time to full feeds and also duration of hospital stay. So IAP recommends probiotic supplementation for prevention of necrotizing enterocolitis in preterm infants. But since there is low to moderate level of certainty, large high quality studies are needed. So how do they work? We have just discussed it. Just a revision: gut barrier enhancement, cytoprotection, adhesion and biofilm formation. So short chain fatty acids, they promote anti-inflammatory responses, nourish colonocytes and lower the pH. TL4 pathway inhibition and immune modulation. So with careful strain selection and optimized dosing, probiotics can effectively prevent necrotizing enterocolitis. Impaired, so this is just revising the thing again. There is PXR activation and tight junction enhancement. So they can help alleviate intestinal lesions by strengthening the mucosal barrier function. Now a word about Bacillus clausii. Bacillus clausii is an extremely stable probiotic that survives the stomach acid, reaches intestinal tract and remains viable in a desiccated state. It has been safely used for decades with good outcome. It enhances gut barrier function, and then there is increased mucin production, decreased gut permeability, altered levels of pro and anti-inflammatory cytokines, and inhibition of enteropathogens. So how does Bacillus clausii work? There is microbial fermentation of complex carbohydrates generating short-chain fatty acids. So deficient short-chain fatty acids have a role to play in NEC. We have discussed that before. And probiotic microbiota counteracts this short-chain fatty acid deficiency, restoring gut health. We have got the strains in Bacillus clausii, that is NR, OC, SN, and T. They are found to secrete acetic acid, propionic acid, and butyric acid. So this study was conducted to show that Bacillus clausii was producing the levels of acetic acid, propionic acid, and butyric acid in good numbers. And hence, they help in alleviating the NEC-induced inflammation and related symptoms. When they have looked at various brands available, Enterogermina seems to match the claim with a homogeneous B. clausii population. So this is again that comparison showing that it works fairly well. It has resistance to all the 4 tested antibiotics. There is lack of contamination and a high bacterial count. Finally, key insights. NEC prevalence. NEC is the leading cause of gastrointestinal disorder in preterm infants and a major cause of death between 2 weeks to 2 months. The preterms are vulnerable. They have lower diversity and underdeveloped immune system, which leads to immune dysregulation. Short-chain fatty acids have a role to play. Probiotics are critical in regulating the gut microbiome, and by producing short-chain fatty acids, they are able to alleviate the inflammation and reduce the pro-inflammatory process. Bacillus clausii has a potential role in NEC-induced inflammation. Finally, we should not forget that as an NEC overall preventive strategies, the first step is maternal health optimization, which means reduce the preterm birth, which is the single most important factor in preventing NEC. Use of antenatal steroids. Then among feeding practices, human milk feeding and a standardized feeding protocols. Regarding probiotics, while studies are on, probiotics are promising. There is an ongoing research to determine the optimal strains, dosages, and treatment durations for preventing NEC. Other considerations also have to be taken into account, like strict infection control, strict hand washing, minimizing infections, fluid restriction, limiting unnecessarily antibiotics, avoiding gastric acid suppression, and reducing exposure to blood transfusion, because they have all a role to play in promoting NEC inflammation. Thank you. NEC in preterms.
Say that they are not routinely used in our hospital setup, and till now there's not much prevalent practice of using these, but we have to be very cautious. You can use it for babies who are down with some kind of predisposing factors for NEC. They can be one target group, and but using it in preterms will come next, and term SG babies could be the second category. This can be introduced in research mode in our setups which are not already used this, to get institutional permissions and recommendations from NF if we require.
Dr. Ankur?
I think, sir, you have covered entirely whole topic of NC in the last slide was the test slide. So there are two comments. One is that whether evidence is there or not. So more than 60 trials, many meta-analysis. So evidence is grade A in favor of